Okay, I'm going to start here in 1 second. I got to test YouTube. Okay, I think everything is working properly. Good morning, everybody. We left off almost finishing chapter 21. We've got just a couple of parasites we want to talk about. As I was looking through this, there were a handful of others that I started thinking about, but that's okay. We can't give you every single organism on the planet. I don't think you want that. Real quickly, before I get into this, to wrapping up this chapter, I want to just mention the third exam. I still am going through stuff, just making sure all of the proctoring stuff is good. That takes, with about 100 students, that takes a little bit of time to get all of those details back. I get little bits. It seems like it just kind of trickles in. So not 100% with all of that stuff yet, but I can tell you score-wise, things looked pretty good. Average. I can't remember the average off the top of my head now. I looked at all sorts of numbers. The high score was a 96. There were handfuls within the 90 range. I took the curve on this one to be, if I remember everything properly, and again, barring any sort of issues, 92, which would make the overall course total, and I will post this, overall course total with the 3 exams at 278 points. So what is that, 22 point total? You should be able to see, I got all of the papers graded. That stuff should be posted on there. You should see all of your scores on there at this point. And again, take that, whatever your total is, out of 278, and that's where you stand currently. This last unit of material, there's massive amounts of information that we're truly trying to cover. And this last exam, although it only covers this material, is going to be twice as many points. It'll be 100 questions, or maybe not quite 100 questions, but worth 200 points. So, like I said before, as we're moving through these specific chapters, there's tables that describe specific organisms that really gives you an idea of who some of these main players are that we're thinking about, and stuff that you would want to have a pretty good handle on, is what I'm hoping for. All right. Any questions before I get going with this? Any questions about the exam or anything? Okay. So, sure, my chat. Okay. We left off, like I said, just a couple of parasites that we want to think about. The first one, acanthamoeba, is with amoeba in the name. You should recognize this is a type of amoeba, a protozoal organism that exists in what we say down here, and this should hopefully be a little bit of maybe a refresher. What was it, chapter 4? The active, the vegetative stage of these parasites we call trophozoites. It's just a generalization. It's when it's moving, feeding, dividing, all of that stuff. We just call it a trophozoite stage. So in this case, it's an amoeboid form that's moving around. And then they also, some, not all, of the protists can form cysts. These are resting stages, potentially with a good handful of these protists. It's the way that we get infected. Not always, sometimes, and as we see in this circumstance, both forms, the cyst and the amoeboid stage, could serve as infectious points in the life cycle of that parasite that can cause problems with us. There's a handful of potentials with the Acanthamoeba. It likes water. It likes cold water or cool water. There's another type of parasite. It doesn't really cause skin and eye infections, but it does cause central nervous system infections. That guy likes warm water. We'll talk about it later, all right? So these guys like cold water. They like unchlorinated water, so fresh water. And in turn, we probably come in contact with these guys, but don't really see any ill effects. It really has to be the right circumstances really to set the stage for some serious issues. So getting into the skin or into the eyes or mucous membranes does set the stage for these organisms to potentially proliferate, and also might depend on the immune status of the individual as far as if it can proliferate or not. There have been issues for sure with the Acanthamoeba and individuals that wear contacts. It has been a contaminant in contact lens solution that you buy commercially. That's an issue. And people have become infected. It can potentially, untreated, can potentially result in blindness. There are other instances where people may make their own solution, contact lens solution. They don't make it and sterilize it. They don't do things aseptically like we're trying to teach you in the lab. They don't do some of this stuff, and so their solution is contaminated from the get-go. They wash their lenses in it and in turn inoculate it right into their eye. That's an issue, all right? So Acanthamoeba causes issues, both skin and eye issues, as we want to think about within here. And here's a couple of extra images. So the cyst stage of Acanthamoeba, the active, the tropozoite, that amoeboid form with it. And one thing, and I've got a pretty good image right here that I want to point out, and this is something that you truly don't need to think about in too much detail, but Acanthamoeba, the acanth means spiky or spiny. And these guys, when I think of amoebas, I think of nice round pseudopods that they push themselves out and move through the environment. These guys have jagged spikes as far as their projections go. And you can see a few of these little things poking out right here. And that's how they move. That also, as we look at that, could maybe make you think a little bit about some of the issues that they may be causing if they're up in your eye. So here we've got an image where we've stained the eye. This is just, it's kind of disturbing to me to look at this. This person's eye, and it's got sodium fluorescent in there that basically shows where the amoeba has been and the destruction that it has occurred within the cornea of the eye. So switching over, get away from that, right to another eyeball that's maybe more disturbing. That's awesome. What a way to start your morning, right? So with this next one, Loa loa, common name for this is the eye worm. Loa loa is transmitted by the bite of deer flies. Here we can see a fly. And these flies in turn inoculate. These guys are roundworms or nematodes. So it inoculates within the saliva or the bite of that fly. It inoculates juvenile stage of the worm. And in turn, we see, here you can see an actual image of the worm within the eye. So that's basically it for these guys as far as thinking these infections. And like I said, there were some that came to my mind, and one of them that I thought, maybe a little better, although this is a disturbing image, is Onchocerciasis. Onchocercus volvulus is the name of it's another nematode. And it causes river blindness, which is easier to say than Onchocerca volvulus. So These guys are transmitted by a black fly, not a deer fly. The black fly bites, inoculates the juvenile worms in the skin. You oftentimes detect or diagnose by a bloodless skin snip. You take a little piece of the skin, snip it off, dissolve it in some potassium hydroxide, and you can see the worms, the juvenile worms, right within that tissue, which is fascinating and also a little bit disturbing. That's where they're initially progressing or manifesting within the skin as that fly is taking a blood meal. And then over the course of infection, they make their way up into the worm. You get all of these juveniles within the worm, destroying the eye and resulting in blindness. That can take years to ultimately manifest that way. And we see these, both of these in third world countries, areas in Africa where there's maybe, especially with the Onchocerca, fast moving rivers. Those flies love that environment, and that sets the stage for potential to become infected. So enough with that. I do see I've got a chat up here. Let me quickly look at this. Will there be extra credit for the final? Oh, like some questions or something? Sure, I'll get something like that together. All right. Points everywhere. Okay. I think that's the end of this chapter. Let me make sure. Oh, here's, sorry, table. Then it's the end. So Acanthamoeba, the disease of Acanthamoeba keratitis or loiasis, and the respective details. You don't need, again, Onchocerca. Even though it's a good one for this, you don't need to think about it. Not that I want you to just ignore him. Okay, let me stop sharing that. And give me a second here. Okay, chapter 22. Back to this. So we're going to shift gears a little bit and talk about respiratory tract infections. And when I think about all of the, unit or chapters, not units, all of the chapters in this last unit, there are a couple that I think are really maybe not that all of these diseases that we talked about in the skin aren't important, all right, but I feel like the respiratory tract diseases are some of the more important types of infectious disease, something that is maybe more relatable. And I also think when we think some of the GI tract issues, both of those chapters are maybe more on the top of everybody's minds, maybe when you think about infectious disease, right? Many probably never thought about loiasis or keratitis by Acanthamoeba. Not something you think about all of the time, all right? But strep throat or pneumonia, those are things that we definitely are maybe a little more familiarized with. I guess with that said, it also might depend upon where you're at. If you're living in an area where these flies transmitting all sorts of crazy parasites, if that's an area where it's super common, that might be more on your radar, right? But for us, it's more stuff like this that we think about as definitely more of a concern. All right. So this image, I'm just thankful we're wearing masks, right? Looking at this, the mask wearing definitely sets the stage to drive a wedge in the potential to transmit all sorts of things by blocking this aerosol transmission. So coughing and sneezing, just simply talking has the potential to release lots of aerosolized droplets that potentially harbor numerous organisms. some of which could be definitely some pathogens, right? Some of these things that we're going to think about as we move through here, definitely pathogens, but some also might be considered normal flora within your mouth. And that sets the stage, as we see this image, to potentially lend to transmission to others through this type of transmission. So massive amounts of organisms can be spread, and the distance with that, well, that's tremendous. Okay, so little anatomy as we move through here, and you don't need to get bogged down with all of these details. You can save that for anatomy if you're in that process. But we are going to think a little bit about the ear and ear infections, and we can think about a couple of potentials. We showed in the last chapter some Pseudomonas and the infection external, where you get Pseudomonas colonizing and causing issues. We're going to think a little more about some potentials that happen on the inside. There's other possibilities, again, for external stuff, but things coming, you know, from the nasopharynx up the eustachian tube and causing inner ear infections, right? And the upper respiratory tract, as we look at this, all sorts of potentials for organisms. When we look at this, numerous areas that we may think of as being, you know, prime real estate for some of these organisms to call home, right? As we move lower into the lower respiratory tract, that becomes a little more inhibitory, and we don't think of as like excellent real estate for all sorts of organisms. Doesn't mean you're not going to find stuff there, right? But nothing like what we see in the oral cavity, right? Really deep down, one of the dirtiest places on your body is your mouth, even if you brushed your teeth this morning, which I hope you did, right? But I'm wearing a mask. That doesn't matter, right? You still should be brushing your teeth, all right? All of those thinking dental hygiene or whatever, like, yep, and you ought to floss too. Okay, that should maybe go without saying. Okay, and here we're moving down lower respiratory tract. So as we move in here, we can see different bronchus, bronchioles. As we zoom in on that, we can see the alveoli, this alveolar sac. This is where we see gas exchange as we blow this up, and the potential for these air sacs to become infected and ultimately issues as we move through here, because we ultimately need this process in the first place. So as we get down in here, we think about pneumonias as potentials as we get in and cause infection within the alveoli. This micrograph is a cross section from a respiratory tract. We can see here the lumen of the trachea. So the here the inside, if you will, where air will be moving in and out. All right, and then on one side of it, we can see the cilial cells, ciliated cells. This is the pseudostratified epithelial cells, and there's goblet cells. Remember, those cells are important for mucus production. The cilia, little whip or brush-like movement that helps to move that mucus, and the mucus trapping things and being moved up and out of there with the motion of the cilia. So this is part of the innate response, providing this initial level of protection that has nothing to do with antibodies or anything like that. All right. So we want to think, starting off, we want to start thinking about upper respiratory tract, and then we will move down. So initially, thinking about some common players Strep throat is something that's really pretty common. It's also pretty contagious, right? So scanning micrograph, I think, some of these micrographs are just totally impressive to look at. It's colored up here, purple. They are gram-positive cocci if you were to look at them through a gram stain. They also divide in a linear plane, giving a long chain of cocci linked together, right? Oftentimes you see numerous cells linked together in a good gram stain, right? Where it's not all thick and stacked on top of one another. You can see nice chains of cells, right? So this is something characteristic of the Staphylococcus, or excuse me, Streptococcus genera, seeing this type of division, but we can divide it a little bit because there are different potentials for the Streptococci, some big long chains, and others like the Streptococcus pneumoniae, typically two of them together, and you see lots of little doublets. We call that diplococci, right? So looking at some of this and knowing a little bit about it can clue you in at least the littlest bit about what you might be really looking at before you've done anything else, right? And there's definitely biochemical tests and other things that we might utilize to ensure that what we're really thinking we've got is accurate, all right? So there's handfuls of things that we think about with Streptococcus. Initially, well, with the Streptococcus pyogenes. So initially with this strep throat, we look in the back of the throat. We see a lot of redness. We see a lot of splotchy bits in there. We call that petechiae. And this is where these cells are getting in and destroying tissue, feeding on blood, all right? Because really, these bacteria thrive on that. If you were to grow them on a blood agar plate, you would see nice hemolysis, beta hemolysis, the complete destruction of those red cells. And that's definitely something that lends to ill effects within us as they get in and start targeting tissues and feeding on red cells. There's also potentials where you may see some pus in the back of the throat, some whitish growth, also can be indicative of bacterial infection, not always saying that's strep throat, but definitely something like that. There's often, a pyogen is a pus producer, and Streptococcus pyogenes should be, kind of that name should imply there's going to be some of that you're seeing, although we're not really seeing that here. But back kind of by the tonsils is where you might be seeing some of that production. So that's the main idea when we're thinking strep throat. Fever, some of this petechial spots in the back of the throat. And that may be all fine and good, and that's all you see. All right. Oftentimes, antibiotics are warranted in these circumstances. You start taking some antibiotics, and fever drops almost immediately. It seems like it's not that quick, but fever drops, and you start feeling better within about a day or two after you've started your prescription. So, again, that may be all that you see. There are other potentials, however, where we can see some other consequences as a result of strep throat. And it kind of just depends on in some circumstances, depends on the bacterium in the first place and if there's other things going on. So scarlet fever is a rash that can be a secondary consequence or sequelae to the initial infection with strep throat. And with that said, you can see here now it's not just localized to the throat. You see this rash that's spread to the body, oftentimes the trunk. covered with this rash. And there's other potential issues as well with this as we think of some immune complexes, destruction in the kidney, the glomerular nephritis as a result, and rheumatic fever is another issue where the immune cells start targeting the heart. So enough of strep throat right now. Here we're moving in thinking about ear infections. So two images, a healthy and an infected ear. So here we could see the tympanic membrane, the eardrum. In a healthy situation, as you're looking in there, you can see through the eardrum like a kind of semi-transparent membrane. You can't, it's not super clear, all right? But as you look through, you can see some of the bones within the middle ear, kind of occluded, but they're there, all right? On the other hand, with an infection, there's all sorts of issues: chronic inflammation, torn membrane, and potentially erosion of those bones. Hearing loss is definitely a potential in these circumstances in a chronic situation. So there's also, you know, a lot of red inflammation and pus production in there as well, mucus buildup. So much good stuff. This next one is looking at the back of the throat, the uvula right here, or as I like to call it scientifically, the hanging down. The uvula here is just all sorts of covered with bacterial growth. We call it pseudomembrane, and diphtheria. Corynebacterium diphtheriae is the culprit for this, and it produces this pseudomembrane. It's basically cells, dead cells, pus, fibrin deposits, and red cells all together in this, well, yeah, pseudomembrane. Here, we're shifting downward, starting to think about some pneumonia. So this could be Streptococcus pneumoniae. I think that's the bacterium we mentioned next. Likely what we're going to think about. It doesn't look like the same sort of lesions that you'd see with TB. We'll see that guy here in a minute, all right? So these consolidations or lesions here showing areas where those, basically the alveoli full of fluid, full of bacteria, causing this occlusion or consolidation in a radiograph. Okay, so here is some Streptococcus pneumoniae. We've got a micrograph, electron micrograph that shows the diplococci, two little purple cells together. There's a couple of others that are in the process, but a gram stain on the other side. The little purple guys all throughout, you can see two cells together, diplococci, all right? And if it was pyogenes, there'd be multiple long chains of these guys, right? There is the potential, Streptococcus pneumoniae does live in the oral cavity, upper respiratory tract. So a throat swab could potentially show both pneumoniae and pyogenes in one gram stain. If you've got a smear, you could potentially snag both of them. Just kind of depends, right? And you may see in a healthy individual that potential, and they don't have any ill effects, all right? At least not at this point, all right? Given the right circumstances, there is the potential for those organisms to infect elsewhere. Another organism that can cause pneumonia is Haemophilus. Haemophilus influenzae is kind of an oddball as far as our bacteria go. These guys require specific nutrients, specific factors that are essential for the bacteria to grow. And if they don't have that, well, you're not going to be able to cultivate them. All right. They like red cells, but they don't have the enzymes needed to destroy the red blood cells. So in these circumstances, the chocolate agar, which is a cooked blood agar plate, basically, it causes those red cells to be destroyed. Now, those factors, NAD is released as those red cells lyse. Heme, an iron-rich component, is also released in the process of this, and Haemophilus thrives when given those ingredients. And you can see this chocolate agar plate is just full of growth. It's nice, shiny, mucoid-looking growth. Capsule production is evident with colonies that look like that. So pretty interesting, all right, to see this. I didn't, and I should have looked for something like this. There is potentials where you can grow Haemophilus on a blood agar plate, all right? I told you just a second ago, it can't do that. It can't lyse those red cells. How can it grow? In order to do that, and oftentimes if you're going to do that, you maybe don't have a chocolate agar plate, but you probably have blood, all right? So what you would do is take your Haemophilus and you would spread it onto this plate, and then you would take a known organism that's beta hemolytic, something that you know will destroy those red blood cells. Staphylococcus aureus is what's typically used, all right? And a good culture of Staph aureus streaked right down the middle of that blood agar plate that's had Haemophilus spread around. The Staph aureus will grow right down the middle where you inoculated it, and it's going to destroy those red cells, and it destroys a little bit on either side of the inoculum. So you get this zone of clear on the blood agar plate, destroyed red cells. And where that clearing is, there's little pinpoint colonies. We call it satellite phenomenon. And it's Haemophilus that's growing around the Staph aureus in that streak. And so you can't, that's another, not only do we help it to grow, it's another way to kind of show you're really looking at Haemophilus, because it's not going to be growing elsewhere on the outskirts because it's still intact red blood cells, right? Only right where it's been lysed. Do you see that? And if you don't know what you're doing, you'd look at it and you'd be like, oh, that plate's contaminated. Look at all these little guys. That's not supposed to be there, but it is, right? Okay, this next image, this type of pneumonia is a little bit different. This image is an experimental thing from a hamster, but Mycoplasma pneumoniae causes a type of pneumonia that we call walking pneumonia. This type of pneumonia is a little bit better, I guess. Not that you want to have pneumonia, but ultimately walking pneumonia because you don't feel super ill. You are able to do some stuff. You feel like you got a pretty bad cold, but you don't feel terrible, all right? Oftentimes, Streptococcus pneumoniae, you are super, super sick. Oftentimes, serious issues with this put you in the hospital, all right? And Mycoplasma pneumoniae, maybe not, all right? Not as severe for sure, all right? That kind of maybe makes you think, that sets the stage. If it's walking pneumonia, you feel like you just maybe have a bad cold, you might still go about your business, right? Setting the stage for you to spread that to others, right? Maybe we should just wear masks for forever, right? Nobody wants to hear that. I don't know. All right. Mycoplasma is weird, right? And I think we mentioned this early on, first unit of stuff. Mycoplasma is one type of bacteria that doesn't have a cell wall, right? Really, the only one we think about in here as having that characteristic, right? So they're very weird. They're very small compared to other bacteria. And they also, we describe them as pleomorphic. They've got the ability to take on any sort of shape because they're not constrained by their cell wall, right? So that also sets the stage for difficulties because you can't gram stain them. There is no cell wall, all right? We typically do other techniques to visualize these guys, right? Again, because they're not going to pick up those types of stains. This is an electron micrograph, so we can see this cell, and it is kind of weird looking as it's trying to get in and infect a tracheal cell, epithelial cell, and the trachea of a hamster. So that's what we're pointing at right here, is it's trying to get in and attach. Okay. The next bit here, tuberculosis. You know, there's all sorts of details about tuberculosis. This is something that has plagued humanity for forever. It's something that, you know, with the discovery of antibiotics, we were pretty sure we had a handle on this. We could treat you, we could cure you. TB becomes an infection of the past, so we think, right? Maybe that's what we think in the United States, right? It's definitely not the case. We maybe just here now consider tuberculosis a re-emerging disease, something that maybe we had a handle on and now it's back, right? I think elsewhere, it never went away, right? And there's issues with that in and of itself. With the overuse and misuse and, you know, with the infectious cycle of tuberculosis, treatment isn't as simple as, you know, taking a handful of antibiotics, you know, a week or 2 weeks worth dose of antibiotics and you're good to go. This is prolonged treatment, right? And that sets the stage for issues. When people fail to comply, resistance becomes a problem, right? This is a big issue, right? So there are massive amounts of individuals that are infected with tuberculosis, right? I can't remember the exact statistics, but it's about a sixth of the population, right? 1.5, almost 2 billion people infected with tuberculosis right now. That's disturbing, right? So some of those infected with multi-drug resistant or flat out all drug resistant strains. How do you treat something like that? It's a good question. So these bacteria are different cell wall wise. They have mycolic acid, a wax-like lipid that makes them typically not pick up a gram stain. If you have an old culture, they may show up as gram positives, but usually a sputum specimen from an individual suspected of having tuberculosis, gram staining it, it doesn't show up. And then you do the acid-fast staining and you see the acid-fast bacilli, which we've got an image of right here. And that is indicative of tuberculosis. It is the only bacterial infection that we can diagnose and start treatment based off of acid-fast staining results. You don't see other bacteria that have this reaction, right? There are some other things, definitely, that will pick up acid-fast staining. Some protists can do that, but we're not thinking pulmonary infection, and they're not bacteria, all right? So staining them, seeing that stuff is a red flag, and it says this person's got tuberculosis. You start treating immediately. They take a super long time to grow partially because of the mycolic acid in the cell wall is, it's a huge energy investment in those cells to build this, and it definitely takes them some time to grow. So it could be a couple of weeks before you get visible culture. That's an issue, right? We don't have time to wait, a month before you get antibiotic susceptibility testing performed. That's an issue. We want to start treating immediately, right? So in turn, we start that therapy, and dependent upon the outcome of the testing that typically is weeks later, the type of drug or maybe the dosage might be altered when we recognize some of the characteristics of the pathogen that's actually infecting you, all right? Because it might be something that's multi-drug resistant, all right? Just depends. So these guys are really pretty crazy with their potentials to infect and evade our immune response, right? So here we can see these bacteria, and as they get in, colonizing within the alveoli, that's what we're looking at down here. You get bacteria in there causing issues that stimulate an immune response, and we try to wall it off. So this granuloma basically forms a shell or a wall around the bacteria, trying to keep it from proliferating, all right? And that's sort of effective, all right, till it's not, as we see right here. And as that granuloma basically gets dispersed, it allows the bacteria that have replicated to be released, to disperse, and for that infection to continue. This right here indicates why you're taking antibiotics for so long, because you've got organisms within these shells, if you will, within these tubercles, that you need prolonged treatment, because when this starts to occur, if you aren't, coursing antibiotics through your system, these organisms aren't destroyed, right? They're not destroyed when they're in this granuloma, and that's an issue, all right? We're not showing all of this because some of these guys will take up residence inside of the white blood cells that should be killing them. The macrophages inside of the lungs, we call those guys alveolar macrophages. They recognize the bacteria and they engulf it. But as it gets phagocytized within that vacuole or that vesicle, as it's ready to fuse with the lysosome, there are enzymes that the bacteria is producing that prevents the fusion of the lysosome to the little vesicle that it's within. And now it grows and replicates inside of the macrophage that should be destroying it, filling it up with bacteria, destroying it, and releasing more bacteria out, and the cycle continues that way. So within the actual alveoli, it may get walled off. Within the macrophages, they can replicate and proliferate. Both circumstances for the bacteria to prevail deep down, even though our cells or our body in general is trying to deal with it, right? So it definitely depends on circumstances, and it depends on the immune status of the individual as far as what sorts of treatment and potential for cure may be there. And definitely there are issues as we think, in the United States, we see tuberculosis, but it's not a huge concern. Elsewhere, It definitely is. And prolonged antimicrobial therapy is a huge issue with non-compliance. So there are people that have been thrown in prison to ensure that they comply, which seems ridiculous, but it happens. There are other ideas where they pay you to come and take your medicine, right? All of those make me wonder, is it effective? I don't know, right? This TB test, Manitou test, many thinking health professions will have this or have already had this to see what's going on. If you have been in the military, often you will recognize positive test. If you are from another country, you oftentimes get vaccinated and would have a positive test as well. It's vaccination with military, not they don't have TB. Uh, Civilians in the United States aren't vaccinated against tuberculosis, not typically, at least, not to my knowledge. But there are, elsewhere, you definitely may see that. So the TB test, they inject a little bit of protein from the bacterium, and if you mount a response, you will have this little welt after a couple of days, right? So it's type 4 response, if you remember that from the last unit. So in order to see that welt up. Okay, so we will see this table and then we will stop. We're right at about quitting time. So there are a handful of bacteria, a couple of these not seen in the image that we've gone through yet. So the otis media, acute otis media, the inner ear infection, right? Handfuls of bacteria, Haemophilus, strep pneumo that we saw, Moraxella catarrhalis is another one. All right, all of these have the potential for inner ear infection. All of them potential living in the oral cavity in the first place. That sets the stage for maybe easy colonization, if you will. Corynebacterium is diphtheria, forming that pseudomembrane, and we can see vaccines with it. The D in DTaP is for diphtheria. Legionnaire's disease, Legionella pneumophilia. I feel like we mentioned Legionnaire's disease a while back. Aerosolized droplets, water droplets, AC units, misters at a supermarket. All of these have potentials to harbor the bacterium and to maybe infect you. Again, sort of with these guys depends on immune status. If you're a little weakened, you may be more likely to contracting it. Whooping cough, pertussis, Bordetella pertussis. It's the P in DTaP for vaccination. Q fever is Coxiella burnettii. It was an infection that was we didn't know what really was causing this fever of unknown origin initially, and there we go. The pyogenes was strep throat and tuberculosis that we were wrapping up with. All right, couple of things. Memorize diseases. I would focus on what we're talking about. The table is good. I would focus more so on what we have covered than some of these. Well, I think the table. Even though we may have not mentioned or seen images of all of these, I think we will see more of them here shortly. So disease, pathogen, symptom. That's these first three definitely. That's so much in these tables. Also with some, I'm moving my chat over. You guys probably don't even see the chat if you're tuning in from home. The potentials over here, as we see some of the vaccines also might be important as we think about possibilities. Many we do not see vaccine, only a few. have that on there. So, okay. Anything else? Okay, guys, I hope you have a great day.